Okay, let's unpack this. When we think about dentistry, our minds often jump to adult procedures. But what happens when the patient is still growing, still developing, and might be, shall we say, a bit of a moving target or even a little anxious? Today, we're diving deep into the fascinating world of pediatric dentoalveolar surgery. We've taken a comprehensive deep dive into the source material, and our mission is to extract the most important nuggets of knowledge to give you a shortcut to being well informed.
What's truly fascinating and often overlooked is that a child's psychological state and a surgeon's understanding of it can be as critical as their technical precision. Imagine a child scarred, not just physically, but emotionally, from a dental visit. That's the hidden challenge we're unpacking, and it's why this field demands so much more than just a steady hand.
That's a powerful point, and something many might not immediately associate with surgery. Today, we're going to explore what makes this field so unique. We'll talk about teeth that don't come in, what happens when there are too many or too few teeth, the surprising possibilities of tooth transplantation, and the complexities of dental implants and growing jaws. Finally, we'll look at prominent frontiera, those small bands of tissue that connect your lips and tongue to your gums. So let's start by elaborating on what really sets pediatric dental alveolar surgery apart from adult dentistry. First, there's the critical aspect of behavioral management. It's not just about what you do, but how you do it. This means understanding a child's psychological development stage and interacting in an age-appropriate way. The primary goal, and this is so important, is to establish a supportive relationship with both the child and their parents before the operation. This isn't just about getting through the procedure, it's about making sure this experience doesn't create a fear that impacts their willingness to seek future medical and dental treatment. If that crucial collaboration isn't possible, then gentle conscious sedation or perhaps general anesthesia might be necessary.
Absolutely. And beyond the behavioral, there are significant anatomic differences. When we're talking about children in the mixed dentition phase, meaning they have both primary or baby teeth and permanent or adult teeth, there's a constant need for special attention to avoid damaging the permanent tooth buds. These are the developing adult teeth sitting just below the surface. Understanding the precise sequence and timing of permanent tooth eruption is key. So interventions can be timed, perfectly to facilitate normal eruption.
Given these delicate anatomical differences and need for careful management, it's no surprise that certain dental issues show up far more often in children than adults. Which ones top that list?
Well, the source material highlights that impacted canines, supernumerary teeth, that's extra teeth, and prominent crina, are conditions we see far more commonly in children than in adults. It's really a testament to how children's oral development is such a dynamic, evolving process.
That sets the stage beautifully. We've highlighted that treating kids is a world apart, but let's zoom in on one of the most common challenges. A tooth that just won't come in. It sounds simple, like a toy stuck in a box, but the reasons behind an impacted tooth are incredibly varied and can have surprising ripple effects on a child's entire facial development.
Right. Let's start with some clarity. An unerupted tooth is one that should come in, but hasn't yet emerged into the mouth. An embedded or impacted tooth, on the other hand, is unerupted because there's either a physical roadblock in its way or it simply lacks the normal eruptive force, the energy needed to push through.
Yeah.
What's crucial here is that normal tooth eruption isn't just about having a full set of teeth. It's essential for the proper development of the maxilla, the mandible, and all the surrounding dentoalveolar bone. Missing or impacted teeth can actually affect the overall facial development, connecting this to a much broader picture of how a child grows.
It really does. And when a tooth fails to erupt, the reasons can be incredibly varied, some quite surprising. While a common cause is simply a lack of space because the jaw isn't growing enough, it goes much deeper. We're talking about possibilities like an overlying cyst or tumor. Imagine looking at an X-ray and seeing a shadowy mass, a cyst for instance, blocking that tooth's path. It's a surprising but very real obstruction. There could also be trauma to the tooth bud itself, or mechanical obstruction from those extra teeth we just mentioned.
Right, the supernumeraries.
Or even conditions like cleidocranial dysostosis, which affects bone development. Less obvious causes include scar tissue from previous surgery, a tooth becoming fused directly to the jawbone, a process called ankylosis, which effectively glues it in place and prevents it from moving.
Yeah, that's a tricky one.
Or even habits like thumb sucking. Sometimes it's about the tooth bud forming in an ectopic or abnormal position or linked to congenital conditions like cleft lip and palate, or systemic diseases such as hypothyroidism. Various syndromes from Crison's to Down syndrome can also play a role. And what's truly humbling and sometimes frustrating for parents is that despite all our advanced diagnostics, Often the exact reason a tooth fails to erupt remains, well, a medical mystery.
Yeah, it really underscores it. Even with all our science, the human body holds its secrets. It requires a blend of art and science in its care.
Exactly. So how common is this?
In terms of prevalence, impacted deciduous or baby teeth are quite rare. If they do occur, it's most often the second primary molar. For permanent teeth, the mandibular and maxillary third molars, those wisdom teeth we often hear about, are by far the most commonly impacted. Following them are the maxillary canines, then premolars, and finally second molars. It's actually quite rare to see first molars and central incisors impacted unless there's some underlying pathology or problem.
Okay. So when it comes to treating an impacted tooth, what are the options?
Well, there are several pathways. Surgical extraction might be necessary if the tooth has significant decay, dental caries, or if it's damaging adjacent teeth, causing gum disease, periodontal disease, or if there's an associated cyst or tumor. In those cases, addressing the underlying problem, the pathology, takes precedence.
Right.
You can also do what's called longitudinal observation, which basically means watching and waiting. But this comes with risks like resorption, where the tooth or bone dissolves, or the development of cysts, tumors, or infections.
So not ideal usually.
Generally, no. The preference, and this is important to note for almost all impacted teeth except wisdom teeth, is usually to expose the tooth surgically and then use orthodontics like braces to help guide it into its proper place.
Got it. Expose and guide.
Precisely. Let's take a closer look at maxillary canines because these are such a common challenge after wisdom teeth. They intact in about 1.7% to 2.2% of the population, and interestingly, females are affected twice as often as males. When they're impacted, they're located on the palate, the roof of the mouth, about 3 times more often than on the labial or cheek side.
3 times more often, wow.
Yeah. Ideally, permanent canines should erupt before the age of 14 in girls and 15 in boys. Crowding in the mouth is often the root cause when they fail to erupt. If these are recognized early, and the impacted tooth isn't too far off course, sometimes simply extracting the primary canine and creating enough space with orthodontics can allow for spontaneous eruption.
So early detection helps sometimes, and if spontaneous eruption isn't likely, what then?
Well, the options are leaving it in place, surgically removing it, exposing it and orthodontically moving it, or even autotransplantation, moving it to another spot in the same person's mouth. While preserving the tooth is usually the goal, there are situations where removing the unerupted tooth can actually shorten treatment time and still give an acceptable result. For instance, if other teeth, like premolars, need to be extracted for crowding anyway, a deep, horizontally impacted canine might be removed instead. Then the premolar can be modified orthodontically and restoratively to look like a canine.
Interesting trade-off sometimes.
Exactly. All of this really underscores the absolute necessity of consulting and coordinating closely with an orthodontist to establish the right treatment plan for that specific child.
Makes sense. You need the whole team involved.
Absolutely. And building on that, the absolutely critical first step in managing an impacted maxillary canine is accurately locating it in 3 dimensions, pinpointing its exact location.
Why is that so critical?
Because if you don't do this precisely, it can lead to prolonged procedures, maybe cutting more gum tissue than necessary, unnecessary dissection, and potentially significant emotional stress for the young patient. That can make them less cooperative for future treatment, as we discussed.
Right, back to the behavioral aspect. So how do you even begin to find a tooth that's completely hidden? It sounds like detective work.
It kind of is. You start with visual inspection, feeling the gums, palpation, and various x-rays, panoramic, periapical, occlusal, and cephalometric views. A neat trick called Clark's rule, also known as the tube shift or buckle shift technique, is used when you can't feel the tooth.
Clark's rule, how does that work?
You take 2 x-rays, usually periapicals, but shift the angle of the x-ray beam slightly between the 2 shots. If the impacted tooth is on the palatal side, it'll appear to move in the same direction as the x-ray beam shifted. If it's on the labial or buccal side, it'll seem to move in the opposite direction.
Clever. Same direction, palatal, opposite direction, labial.
Exactly. If it's right in the middle, in the arch, it won't appear to shift much relative to the adjacent teeth.
Okay, that helps narrow it down.
And this is where technology has really advanced things. Cone beam computed tomography, or CBCT, provides incredibly valuable 3-dimensional visualization.
Ah, the 3D imaging.
Right. It shows the impacted tooth, the surrounding bone, and importantly does this with a relatively low radiation exposure compared to traditional medical CT scans.
Lower radiation is key for kids.
Absolutely. While it's not needed in every single case, CBCT can give us crucial information. The tooth's exact position, its angle or inclination, how much bone is covering it, its proximity to adjacent roots, and whether it's causing resorption, that dissolving away of those roots. It also shows the position of important anatomical structures like the maxillary sinus, the nasal floor, nearby nerves, and the tooth's overall development stage.
So a much clearer picture.
A much clearer picture, and because of the higher radiation dose, conventional CT scans are generally avoided for this purpose in children.
Makes sense. Even with all this precision, though, I imagine complications can still arise with the surgery itself.
They can, yes. Potential complications include infection, numbness, or tingling paresthesia of nerves, like the infraorbital nerve under the eye or the nasopalatine nerve in the palate. There's also risk of damage to adjacent structures like roots, the maxillary sinus, or the nasal floor. Sometimes, despite all efforts, the tooth just fails to erupt after exposure.
Oh, that must be frustrating.
It can be. Other issues might include flat necrosis, where the gum tissue doesn't heal properly, or problems with the amount of attached gingiva, that firm gum tissue, or the bone level around the tooth once it's exposed. It's a complex procedure.
Definitely sounds like it. So walk us through the surgical techniques. Let's start with those more common palatally impacted canines.
Okay. For a palatally impacted canine, the surgeon typically makes a sulcular incision, sort of tracing around the necks of the adjacent teeth on the palate side. They lift a full thickness flap of gum tissue, exposing the bone. Then, bone covering the crown of the impacted tooth is carefully removed, maybe using a small elevator, a wronger, or dental drill, a burr. The dental follicle, that tissue sac around the developing tooth crown, is removed using curettes or maybe electric cautery. Using electric cautery can help keep the area dry, which is good for bonding the bracket later.
Right, you need a dry surface for the glue.
Exactly. It's important to gently shave the bone away, just enough to expose the crown, but avoid removing bone all the way down to the cement enamel junction, the neck of the tooth, to preserve future support. Then you check if the tooth has any mobility. If its position is favorable, sometimes just excising the overlying gum and bone is enough, creating that window for it to erupt on its own.
And if it's deeper or angled badly.
Then, an orthodontic button or bracket, often with a tiny gold chain attached, is bonded near the cusp tip, the pointy part. Gold chain is excellent because it's flexible and doesn't corrode. This chain or wire is then gently guided out through the initial incision, or sometimes through a separate small window created in the palate flap before it's stitched back.
Okay, so you attach something to pull on it.
Essentially, yes.
Yeah.
The key is guiding the eruption palatally towards the roof of the mouth, and crucially away from the root of the adjacent lateral incisor to prevent resorption of that root or the bone around it.
Got it. What about the labially impacted ones on the cheek side? Is it similar?
The principles are similar, but there's a critical difference. You have to pay specific attention to preserving the attached gingiva, that firm, protective gum tissue on the outside. Electrocautery is generally avoided here because it can damage that keratinized tissue.
So preserving the gum tissue is paramount there.
It really is. The recommended technique is often an apically repositioned flap. This involves making an incision on the alveolar crest, the ridge of the gum, maybe with vertical releasing incisions on the sides. If the primary tooth is still there, it's extracted. The flap of gum tissue is elevated, bone is removed to expose the canine crown, the follicle is removed, and a bracket is bonded, just like on the palatal side.
Okay.
But then, the flap is sutured back in a position slightly lower down apically towards the root tip. This ensures there's enough attached gingiva around the tooth when it erupts.
Ah, so you move the gum tissue down with it.
Precisely. There's an alternative called the closed eruption technique, where you bond the attachment and suture the flap back completely, letting the tooth erupt through the gum later. But that can mean increased treatment time, less control over its movement, and sometimes needs more surgery later on.
Sounds like the apically repositioned flap is generally preferred then.
Often, yes. A soft periodontal dressing might be placed over the area for comfort during healing as well.
Now, you mentioned autotransplantation earlier as a last resort for canines. Tell us more about that.
Right, so autotransplantation is considered for canines that really can't be moved orthodontically, perhaps because they're too deep, too horizontal, maybe an angulation greater than 45 degrees or very close to the midline. It involves a very careful atraumatic extraction of the impacted canines, moving it into a socket prepared in the correct position in the arch, and then stabilizing it, usually to an orthodontic arch wire, for about 2 to 3 weeks.
Does it work well?
Studies show a success rate of around 70%, which is pretty good, considering the alternative might be losing the tooth. However, there's a risk of external root resorption, where the outside of the root starts to dissolve. If that happens, usually within the first 2 years, endodontic treatment or root canal might become necessary.
Okay, 70% is significant. Let's move beyond canines. What about other impacted teeth?
Premolars. Impacted premolars are actually more common in the lower jaw, the mandible, than the upper. The second lower premolar is the second most common impaction after wisdom teeth. They're usually found towards the tongue side, lingually, or sometimes right in the middle of the jawbone. Maxillary premolars, like canines, are often impacted towards the palate.
And the treatment approach.
It's similar. First, create space, maybe extract the primary molar if it's still there, or use orthodontics. If it doesn't erupt spontaneously after space is made, then surgical exposure and bracketing are needed. A key point for lower premolars is being extremely careful during exposure to avoid damaging the mental nerve. That's the nerve that exits the jawbone in that area and provides sensation to the lower lip and chin.
Right, nerve damage is a serious concern. What about front teeth, the incisors?
Impacted maxillary incisors, the upper front teeth, have a lower incidence than canines or premolars. You might see them more often after trauma to the primary incisors, or if those baby teeth were lost too early, leading to thick, fibrous gum tissue blocking the path. Supernumerary incisors, especially mesiodons, that extra tooth right in the middle, are a common cause too.
That mesiodons again.
Yes, it's a frequent culprit. It's really crucial to remove these supernumeraries when the roots of the permanent incisors are about half to two-thirds formed to give the permanent teeth the best chance to erupt normally.
And exposing the incisor itself.
The technique depends a bit on whether the root is completely formed or still developing, but the principle is the same. Expose the crown, maybe bond an attachment, and guide it into place, ensuring good gum tissue around it.
Okay. And finally, molars. First and second molars.
Impacted first and second molars are less common, but they can cause significant problems with gum health and the bite, the occlusion. Diagnosing and treating these early, before the roots are fully developed, offers the best chance for spontaneous eruption after creating space. If the roots deform significantly as they try to erupt in a tight spot, spontaneous eruption becomes almost impossible.
So early diagnosis is key there too.
Definitely. For impacted second molars, treatment often involves removing the third molar, the wisdom tooth behind it, to create space. This can allow the second molar to upright itself, maybe with some orthodontic help. Surgical exposure techniques are then used as needed.
Got it. Now let's shift gears slightly and look at when there are too many or too few teeth. Starting with too many supernumerary teeth or hyperdontia.
Right. Hyperdontia is simply an increase in the number of teeth. It's often thought to happen if the dental lamina, the tissue that forms teeth, gets a bit overactive and forms extra tooth buds. It can also be associated with various syndromes like cleidocranial dysplasia, which affects bone and tooth development, think multiple supernumerary teeth and impacted permanent teeth, and others like Abertis, Crouzons, Down syndrome Gardner's. Quite a list.
But most cases aren't syndrome related.
No, most often it's just a single extra tooth. And the most common type by far is that mesiodons, found right between the upper central incisors.
There it is again.
Yep. And as we said, it's really important to remove that mesiodons relatively early, typically when the roots of the permanent central incisors are about half to two-thirds formed. This prevents it from causing problems like delayed eruption, rotation, or displacement of those important front teeth.
What about other extra teeth?
We also see supernumerary fourth molars, sometimes called distomolars, way back behind the wisdom teeth. And supernumerary premolars can occur too. And occasionally you hear about natal teeth, teeth present at birth, or neonatal teeth, which erupt shortly after. These are usually extra primary lower incisors and might need removal if they're loose and pose an aspiration risk, or if they interfere with feeding.
Okay. Now on the flip side, what about hypodontia missing teeth?
Hypodontia is the absence of one or multiple teeth, and it's actually quite a common developmental anomaly. It can be linked to syndromes like ectodermal dysplasia, which affects hair, skin, nails, and teeth.
Yeah.
In severe forms, it can lead to anodontia, the complete absence of all teeth.
Yeah. No teeth at all.
It's rare, but it happens.
Yeah.
More commonly, people are missing just a few teeth. The most frequently missing are third molars, wisdom teeth. After that, it's often first and second molars, then second premolars, and maxillary lateral incisors, the ones next to the front teeth.
Any groups more likely to have missing teeth?
Yes. Patients with cleft lip and palate have an increased incidence of a missing lateral incisor on the side of the cleft. A key point with hypodontia is that the absence of teeth can adversely affect the development and growth of the alveolar bone, the part of the jaw that supports teeth. So a common strategy is to try and keep any deciduous or baby teeth in that space for as long as possible, until a permanent replacement can be considered later in life.
That makes sense. Hold the space. Which brings us nicely to replacing missing teeth. Let's talk about tooth transplantation first.
Okay, autologous tooth transplantation, where you move a tooth from one spot to another in the same person, has actually become less popular with the rise of dental implants. However, it definitely still has its uses, especially as a potentially lower-cost replacement option in certain situations.
Why only from the same person? Can't you use a donor tooth?
Well, allogenic tooth transplants, meaning from a different person, ultimately fail. The recipient's immune system recognizes the periodontal ligament, that crucial tissue holding the tooth in the socket, as foreign, mounts an attack, and this leads to root resorption and eventual loss of the tooth.
Ah, the immune rejection issue. So autologous is the way to go. What are the common scenarios?
The most common auto transplants involve moving those impacted canines we talked about into the right spot, or using third molar's wisdom teeth to replace missing first or second molars, perhaps lost due to decay or trauma.
What makes for a successful transplant?
Several factors are key. The donor tooth needs to be free of infection and ideally have at least 50%, but preferably 2/3 of its root developed. Immature roots have a better chance of revascularizing. Very careful, atraumatic extraction is critical to preserve the periodontal ligament cells on the root surface. Those cells are vital for reattachment and long-term success.
So handle with extreme care.
Absolutely. The success rate is often quoted around 72%, but initial stability in the new socket is important, and success is inversely related to how long the tooth is out of the mouth during the procedure. Keep that time minimal.
What about root canals?
Some used to recommend prophylactic endodontic treatment, or root canals, but generally now it's only done if signs of external or internal root resorption are seen later, or if pulp necrosis occurs.
And potential complications.
The main ones are ankylosis, the tooth fusing directly to the bone, preventing normal movement resorption of the root, or infection around the root tip, periapical pathology.
Okay. How is it actually done, say, transplanting a molar?
Well, first, the recipient site, where the tooth is going, must be healthy, no infection. The donor tooth, usually a wisdom tooth, is extracted with extreme care, trying not to damage the root or scrape off that periodontal ligament. The tooth is then gently inserted into the recipient's socket. Sometimes a little bone needs to be removed from the socket walls to get a good passive fit. You position it carefully, usually just slightly below the biting surface, to avoid heavy chewing forces during initial healing. The gum tissues are sutured neatly around the tooth.
How is it held in place?
Often, just the sutures and maybe a soft periodontal dressing are enough. Sometimes, temporary stabilization with a flexible wire bonded to adjacent teeth might be used for a week or two. Prophylactic antibiotics are typically given for about a week. Ideally, if the root isn't fully formed, the tooth should then spontaneously erupt the rest of the way into the correct biting position.
Fascinating alternative. Now let's tackle the really complex topic, dental implants in the growing child. We know they work well in adults, but you hinted they're tricky in kids. Why?
Yeah, this is a crucial area. Implants have high success rates in adults, which naturally raises the question, why are they so challenging in children? The absolute key reason is that an implant lacks a periodontal membrane. That's the ligament, the natural cushion surrounding real teeth.
Okay, no cushion. Why does that matter?
That periodontal ligament does more than just cushion. It responds to chewing forces and signals bone remodeling and growth. Implants, being fused directly to bone, osseointegrated, don't have this mechanism. So as the adjacent alveolar bone continues to grow vertically throughout childhood and adolescence, the implant doesn't move with it. It stays put.
Ah, so it gets left behind.
Exactly. It becomes progressively submerged relative to the adjacent teeth and the growing gum line. It ends up looking like an ankylosed or fused tooth too short, too deep. This leads to poor aesthetics and makes restoring it properly very difficult later on.
I can picture that, like a post stuck in mud while the ground level rises around it.
That's a good analogy.
Yeah.
And it's not just vertical growth. The jaws also grow wider transversely. Transverse growth of the maxilla, the upper jaw, can cause implants placed early to end up positioned too far towards the palate, the roof of the mouth, over time.
Oh, interesting.
This is why fixed bridges or prostheses supported by implants that cross the midline should generally be avoided in growing kids, in both the upper and lower jaw, because they can restrict that natural transverse growth.
So growth is the major obstacle.
It is. And the consequences of that implant submergence are significant. Difficulty restoring it later, a poor root-to-crown ratio which affects stability, and just plain poor aesthetics because the gum margin ends up way too high up or apical compared to the natural teeth.
So are there any situations where implants are used in children?
Yes, there are rare specific indications. One is certain genetic conditions like severe ectodermal dysplasia where many or all teeth are missing. In these cases, growth patterns can be abnormal anyway, and implants might offer significant functional and psychological advantages over removable dentures, even if placed earlier. Another indication is in jaw segments that have been reconstructed with bone grafts, say after tumor removal. In these areas, no further natural growth is expected, so implants can be placed to help preserve the grafted bone and allow for tooth replacement. They might need modification over time, but they serve a purpose there.
So very specific, limited cases.
Very specific. Generally, the rule is to wait until growth is complete, or very nearly complete, before placing implants in children and adolescents.
Okay, that clarifies the implant situation. Let's round out our deep dive with frena, that little band of tissue. Parents often worry about the one under the upper lip, right?
Yes, the maxillary labial frenum. It's often a parental concern because a prominent one can be associated with a gap, a diastema, between the two upper front teeth. But it's important to know that frena are often naturally more prominent in young children and tend to become less noticeable as the jawbone grows vertically.
So it might just resolve on its own?
Often, yes. A frenum usually only contributes to a persistent diastema if it's really thick, fibrous, and attaches low down, crossing the alveolar ridge and inserting into the incisive papilla, that little bump of gum tissue right behind the front teeth.
How can you tell if it's doing that?
A classic sign is blanching. If you gently lift the upper lip, you might see that incisive papilla turn white because the frenum is pulling on it so tightly. Of course, other things can cause a diastema too, like thumb sucking, tongue thrusting, or missing lateral incisors.
Now, you mentioned timing is critical here. When should a frenectomy, the removal, be considered?
This is where it gets really interesting, and it's a common point of confusion. In infants, a prominent labial frenum that attaches right down at the gum line is actually completely normal.
Normal in infants.
Yes. With the vertical growth of the upper jaw as the permanent teeth come in, that frenum attachment typically migrates upwards, away from the teeth, and assumes a normal position in most children. Crucially, a frenectomy for diastema closure should generally not be performed before the permanent canines are erupting. That's usually around ages 11 to 13.
Why wait for the canines?
Because as the permanent canines erupt, they naturally put pressure on the roots of the incisors, often pushing them together and closing the diastema spontaneously.
Ah, nature's orthodontics.
Exactly. Performing a frenectomy too early, before the canines come in, can actually create scar tissue between the central incisors. The scar tissue can then make it more difficult to close the diastema later, even with braces.
So intervening too soon can backfire.
It absolutely can. Indications for frenectomy, other than a persistent diastema after canine eruption, might be if it's causing pulling on the gums leading to recession, or sometimes purely for aesthetic or psychosocial reasons if it's exceptionally prominent and bothering the child.
Okay, so patience is key. If a frenectomy is needed later, how is it done?
The standard technique involves removing the fibroelastic band of tissue completely to prevent it from growing back. Histologically, frena contains elastic fibers. An elliptical incision is usually made, starting near the incisive papilla and extending up into the inside of the lip, removing the entire band down to the underlying bone, the periosteum. The resulting diamond-shaped defect is often left open to heal naturally from the bottom up. That's called healing by secondary intention. It usually heals quite well.
Any special care needed?
Generally, no prophylactic antibiotics are required. Just good oral hygiene and maybe a soft diet for a few days while it heals.
What about lasers?
Laser frenectomy is another option. It can offer advantages like a shorter operating time, potentially less bleeding, and maybe less postoperative swelling and discomfort. However, patient cooperation can be an issue, especially with younger children. The noise of the suction needed to remove the laser plume, the smell. It might still necessitate conscious sedation or even general anesthesia in some kids.
Trade-offs there too. What about the lower lip frenum?
The mandibular labial frenum, between the lower central incisors. A high attachment here, close to the gum margin, can cause problems. It can pull on the gum tissue, leading to inflammation, gingival recession, where the gum pulls away from the tooth, exposing the root, and potentially even localized bone loss. Food trapping and plaque accumulation can also be issues.
So more about gum health down there.
Often, yes. If these periodontal problems persist despite good oral hygiene efforts, then a frenectomy is indicated.
Same techniques?
The standard technique is similar to the maxillary one. However, another very useful technique here is the Z-plasty.
C-plasty. Sounds geometric.
It is. You make incisions in a Z shape. When you transpose the flaps created by the Z, it changes the direction of the final scar and very usefully actually lengthens the tissue in this case, lengthening the vestibule, the space between the lip and gums. You can get up to 75% length gain with the right angles.
Clever. Lengthening by rearranging.
Exactly. And laser frenectomy is an option for the lower labial frenum as well.
Okay, one more frenum to cover the one under the tongue. Tongue tie.
Right, the lingual frenum. Ankyloglossia is the technical term. This is where the frenum attaches high up near the tip of the tongue and often anchors it down to the floor of the mouth or the lower gum ridge. This restricts tongue motion, particularly protrusion, how far you can stick your tongue out, and elevation, lifting the tip up towards the palate.
Parents often worry about speech with tongue tie, right?
They do, and pediatricians too. While a severe restriction can impact articulation of certain sounds, it's important to know that many children with a visible tongue tie develop perfectly normal speech. Consultation with a speech pathologist is definitely recommended if there are concerns. Besides potential speech issues, a tight lingual frenum can sometimes contribute to a diastema between the lower central incisors or cause gum recession there due to the pulling action.
So if it needs treatment, is it just a simple snip?
Sometimes, for a very minor tie in an infant, a simple snip, a frenotomy, might be done. But for a more significant tongue tie causing functional problems, simply cutting through the frenum isn't usually sufficient. It can just heal with a linear scar that still limits mobility.
So what's done for a more significant tie?
For a more complete release and to actually gain length on the underside of the tongue, the frenum should be fully excised, and then either a VY closure or a Z-plasty technique is used.
Like in the lip.
Similar principle.
Oh.
With VY closure, you make a V-shaped incision as you remove the frenum, and then you suture the wound closed in a Y shape. This effectively lengthens the ventral surface of the tongue. It is. The Z-plasty works similarly here, rearranging the tissue to gain length. These procedures usually require conscious sedation or general anesthesia because they're more involved than a simple snip. A key point with lingual Z-plasty is that the lower part of the incision, down on the floor of the mouth, is often left to heal by secondary intention. This helps prevent accidental damage to the submandibular ducts, Wharton's ducts, which carry saliva from glands under the jaw.
Important safety consideration. Laser option here, too.
Yes, laser frenectomy can also be used for the lingual frenum, with similar potential pros and cons regarding cooperation and anesthesia needs as the labial frenum.
Wow, okay, we've covered a huge amount of ground, from impacted teeth to implants to frena. So wrapping this up, what's the big takeaway for our listeners?
I think the main point is that pediatric dentoalveolar surgery is truly a specialized field. It's absolutely not just mini adult dentistry. You're dealing with growth, development, unique anatomical challenges like those tooth buds, and critically, the behavioral and psychological aspects of treating children. The techniques have to be tailored specifically for these growing individuals.
Yeah, it really underscores the complexity.
It does. And if we connect this to the bigger picture, it really highlights how profoundly interconnected everything is during development. Understanding those developmental stages, not just treating a specific problem, is critical. It kind of raises a broader question, doesn't it? How else might focusing more on understanding development rather than just focusing solely on disease pathology change how we approach healthcare for people of all ages?
That's a really thought-provoking question to end on, thinking about health through the lens of development. Well, that's another deep dive into the fascinating world of specialized knowledge. We hope you found this exploration of pediatric dentoalveolar surgery informative. Until next time, keep exploring, keep questioning, and keep getting well informed.